All right, so we are here today for the Our Streets panel is over the counter enough, getting naloxone to the people who need it most. And I am joined by some fantastic panelists. I'm going to go ahead and start jumping into just a little bit of background information as more participants join us or audience members join us. So at this point, most folks across the US are familiar with the overdose death crisis that we've been seeing, right? And with overdose deaths continuing to surge across the country, it's really no surprise that the overdose reversal drug naloxone, which many people might know by its brand name Narcan, has become something of a household name. During an overdose, for folks who aren't as steeped in this as we are, breathing slows, it can become shallow. In worst case scenario, it can stop altogether. Naloxone works, it's an opioid antagonist. So it works by binding to the opioid receptors in the brain, moving other opioids off of them, not letting them attach in the first place. And by doing this, it restores breathing within minutes. And this is key, if it's administered promptly and within a reasonable amount of time, it can really make a big difference. It was first approved for overdose reversal back in 1971 and is currently available in the US in two main forms. There's an injectable solution and intranasal formulations. Research shows us time and again that naloxone is very effective and incredibly safe, including when it's administered to someone who has not consumed any opioids, and including when it's administered by someone with zero medical background or training. In fact, it's been deemed so safe that earlier this year, the FDA approved several intranasal naloxone products for over-the-counter retail sales. So while some people, myself included, have argued that this move could have some positive consequences, hopefully decreasing stigma, I was really excited when I went to a local pharmacy recently to pick up a prescription, and there was a big kiosk of naloxone just right there. Seeing that on a daily basis for people, or just in a regular place, we hope could really reduce stigma. There's also some hope that it will remove logistical and privacy barriers that are encountered by some who are trying to purchase it behind the pharmacy counter. However, we've also got a lot of experts who have noted that over-the-counter OTC status just doesn't do enough to improve access, especially for the people who need it the most. So if we're thinking population level impact, if we're thinking really putting the brakes on this ongoing crisis, we need to do more. So that's why we've brought together this panel today. We've got experts in policy, pharmacy, and harm reduction to talk about what intranasal naloxone's new OTC status does and does not do, and what lawmakers and regulators need to be thinking about if we're really going to get the medication into the hands of the people who need it most. So welcome. I'm Stacy McKenna, Senior Fellow in Integrated Harm Reduction Policy here at the R Street Institute. I'm joined by Eliza Wheeler, who's co-director of Remedy Alliance for the People, alongside Maya Doe-Simpkins, who she's worked with for over 20 years to expand access to naloxone, among other things, to harm reduction programs. Remedy Alliance is a nonprofit, high-volume, low-barrier distributor of naloxone directly to harm reduction programs throughout the country. We have Rachel Berney, an associate professor at the University of Tennessee Health Science Center, where she teaches pharmacy law to students and provides continuing education on various law topics to pharmacists, technicians, and other healthcare practitioners. And finally, Katie Green, a director at the National Academy for State Health Policy, where she works on projects related to substance use and public health, including public health modernization and immunization. So welcome to all of you and to our audience. And as we get started, I think anytime we're talking about naloxone, we really need to start with why it matters, like who needs to get it and why does that matter, right? So I think it's really important for folks to understand the state of naloxone access and this idea of community saturation that sometimes gets thrown around and talked about. So I'm thinking maybe, Eliza, we can start with you. When we're talking about naloxone access, whose access are we really talking about? And where are those people often getting naloxone?
Yeah, thanks. I'm happy to be here. This is my life's work. So I've been at it for multiple decades. And I think where to start is with the person who is overdosing. So that is sort of what we need to work. That is the person who we need to work out from in all thinking about how to implement the most effective form of naloxone distribution. So naloxone distribution was a innovation of harm reduction. It first began in 1996 on a syringe service programs van in Chicago. Until that point, naloxone was only used in emergency medical settings and by emergency medical services personnel or in hospital. And harm reduction folks and people who use drugs advocated to get access to the antidote to overdose so that they could manage and respond to overdoses themselves outside of the healthcare and medical establishment and outside of the criminal justice system, both systems that have historically been not helpful for people who use drugs. So this was an intervention around, always was an intervention around autonomy, self-reliance, and liberating a medicine from a institution that controlled its access. So there was not substantial buy-in to naloxone distribution until less than 10 years ago. So for many, many years throughout the 1990s and most of the 2000s, most naloxone distribution was happening by harm reduction programs outside of a legal framework. So the evidence to the effectiveness of naloxone distribution is based on a set of peer-reviewed journal articles and studies that started emerging in the late 1990s, early 2000s, and then throughout the mid and late teens. And all of the evidence for the effectiveness of naloxone distribution is predicated on essentially a set of conditions. So naloxone has to be distributed directly to people who use drugs in a high volume. That's it.
It's like the naloxone needs to be distributed in a high volume.
The naloxone needs to be distributed in a high volume to people who use drugs. That's it. Yeah. So if you are implementing a naloxone distribution intervention that does neither of those things, you are maybe affecting some positive change in some other ways. Decreasing stigma is one. Increasing acceptance and knowledge around overdose and opioid use among a more general population. Sort of changing ideas. Are you actually going to reverse overdoses? Unlikely, or in very, very small volume. So the overdoses are that happen with a bystander. The bystander is typically another person who uses drugs or in close social proximity to someone who uses drugs. So that person, that bystander, has to be the person that always has naloxone on hand. So I think that we have strayed far from that in the last 10 years. And my focus in my work has always been making sure that harm reduction programs, the innovators of this intervention, the evidence base of this intervention are the ones at the center of receiving naloxone to distribute, and that people who use drugs are the recipients. So
Thanks. Yeah, and I think that's really important, right? Some of the research has shown that the vast majority of successful overdose reversals are happening by people who use drugs, right? So we do have data to support that. Rachel, is there anything you would want to add in terms of when we're thinking about access and like how are we getting naloxone into communities, and how are those individuals actually getting naloxone?
Absolutely. Just a few things to be brief here. But I think from the lens of maybe the pharmacy, teaching pharmacy law, being a pharmacist, I'm thinking who do we want to get access to it? Well, one, those at risk, which is really duplicative of what Eliza just said. So that's the person that does overdose or may overdose, maybe because of the drug use they're doing, or because of they're at risk. They may be taking several medications that puts them at higher risk for this. There could be several reasons that they may be at risk, and any other person who could help that person. It's harder to find someone that naloxone isn't appropriate for than it is. When you think of the people at risk for overdosing and who can help them, that really covers the gamut. It's incredibly broad. So that would just be what I would have to add to that.
Yeah, no, great. That's really helpful. And I think, if we remembering that connection always back to the people who use drugs. And one thing I'll add that's interesting that I've seen in the data recently, or that people have started to talk about, is we are starting to see more public overdoses. Like in Denver, it's being an issue where complete bystanders who maybe are strangers to the people are maybe likely to reverse an overdose on someone they don't know. And this is a great reason to maybe carry naloxone, even if you don't immediately think you're going to be that person. But I think it goes back to what Eliza and Rachel both have said, right? Where the biggest impact, like that's a benefit and it could save a life. But if we're thinking big picture population level impact, which is what we're thinking about when we're talking policy, it's really about what can we do to get the drugs or the medications to the folks who are at most risk of overdose, and to the people who are immediately around them, which is often people that they use drugs with.
I also think just to contextualize my comments, is the context in which I work is the administration of public funds.
Yeah.
So I work in a realm where public funds are used to purchase naloxone for distribution. And so I also agree that everyone should have the opportunity to walk into a pharmacy and get access to naloxone if they have $50. But I do think that there needs to be thoughtfulness and strategy around the use of public funds and where they go, because the kind of public blanketing of naloxone distribution using public funds tends to follow politics and politically palatable populations, which don't include people who use drugs. And so you see public funds getting used to purchase millions of dollars worth of naloxone that end up getting distributed to the general public or to programs and entities that are less likely to use them, and then they sit and expire. So yeah, just to contextualize those comments around.
Yeah, no, and I think this is really important, right? Because we are talking about the use of public funds and responsible and efficient use of what are often limited public funds. So yeah, thank you for that clarification. So let's go ahead and move on to some of the things that affect people's ability to access naloxone, right? So what are some of the things that stand in people's way, and not just policy, but thinking socially too? Maybe we'll start with you on this, Rachel.
Absolutely. And one thing's already been mentioned. Yeah, it's great if you have $50 or $45 to be able to buy the, over-the-counter Narcan that's available. So one, I think cost, whether it's cost to pay for it over the counter, cost through whatever it costs. If you have insurance that you actually get to bill for it, whatever your copay is. If it's the other thing too, availability. Is your pharmacy stocking it? Do you have access to a community program where you can obtain it? Or here in Tennessee, syringe service programs, while they're available, they're not in every county. So not every patient is going to be able to drive 1 or 2 hours, just like if they needed to go to an opioid treatment program, it's not always on the table for everyone. So I think that kind of goes into the availability piece. Stigma, of course, it's substance use disorders are highly stigmatized. When you want to get naloxone, maybe because you have a friend or a brother or yourself, when you have to go to the pharmacy and ask to get it, even if it's not pursuant to a prescription, having to ask and having to be vulnerable is a barrier because of the stigma around it. I would say 3, 2, lack of knowledge about the drug. There's a lot of misconception about how effective naloxone is and how next to no adverse events people have from it, even if they're overdosing on an opioid and something else, or they're overdosing on something else completely. We just don't know what they're overdosing on. And the other one too, I'm gonna put my other hat on, fear of legal ramifications. I'm afraid to get sued. I'm afraid to administer this. I don't want this person to be revived and sue me. I'm afraid to dispense it, that someone may take it and use it. And I'm, for lack of a better way to say, people have a mistake that I'm enabling something, when in reality, we know we need to help patients to treatment. Return to use is part of the disease because substance use disorders are diseases. There's a lot of lack of knowledge and just a lot of fear. We highly regulate this area. And I know that there are attempts to make patients as well as providers who prescribe it immune from civil and criminal, depending on your state. But some states have been more proactive in that space than others. And I think that, so I would say those kind of 5 big things: cost, stigma, lack of knowledge about the drug and its efficacy, limited availability of it, and then just fear of those legal repercussions that may rarely arise.
Yeah. So I wonder, Katie, this might be an area where you can help us think about some of the specific policies that have historically or currently shifting to make it harder or easier, sort of building on that issue of fear around liability and Good Sam laws, or how insurance might play a role or things like that, since you're pretty familiar with our state by state policy conversation.
Yeah, and I'll say Rachel did a really good job of sort of calling out some of those specific barriers, cost being a big one. In terms of the population that is most at risk for an overdose, you know, the idea that you need to have insurance, the need that you need to go into a pharmacy can just really create some barriers. So, you know, all for some of the strategies around reducing the out-of-pocket costs, requiring insurers to cover it, covering it within a Medicaid formulary, I think are really important. But, you know, Rachel also brought up some really important points around fear of prosecution, fear of, you know, legal liability. I think those are all things that really affect, you know, people's willingness to carry naloxone, people's willingness to deploy it. So, you know, by and large, almost every state has a Good Samaritan law at this point. Most states have a standing order that can lower some barriers for accessing naloxone outside of some of the traditional ways that it's been in the past. But I think generally efforts to sort of lower those barriers in whatever way possible are something that states can and should be focusing on. And happy to talk more about some of the things that we've seen in terms of how states are lowering barriers to through vending machines or nalox boxes or fentanyl test strips, through SOAR funding and kind of other creative ways to spend those public funds.
Yeah, for sure. And I think, you know, it's interesting with talking about, when we talk about the policies, the Good Samaritan laws in particular, right? They're one that they're of mixed quality, of course, when we look state by state. But one of the things that I notice is there's also a lot of people lack knowledge or understanding of the Good Samaritan laws. So the state might have a good policy, but then how do you make sure that people in your state actually understand that? Yeah. And I've seen some studies that actually people's concern about criminal liability or the assumption that they use drugs if they carry naloxone can feed into a hesitation to carry it, because they don't want those assumptions made either by people they know or by law enforcement or other folks they might come into contact with. Eliza, did you want to add anything in terms of factors that either hinder or facilitate access to naloxone?
Sure. I think that often we'll sort of dance around the piece of this puzzle that is the primary, most impactful mechanism by which naloxone is distributed to the people at highest need in the highest volume, which is harm reduction programs that are providing direct services to people who are at great risk for overdose every day. And so harm reduction programs already distribute the highest volume of naloxone. And they are the infrastructure that needs to be invested in order to make sure that, you know, the term saturation's been thrown around a lot in the last couple of years, especially after the Lancet piece, and the how you get to saturation is by like supporting the actual structural mechanism by which saturation happens. And so in states that have a really robust and well-resourced harm reduction infrastructure that is supported by state monies and invested in, we see extraordinarily high volumes of naloxone getting distributed exactly to where it needs to go. Places like New York, like Massachusetts, New Mexico, you know, places that support safety net distribution mechanisms, things like Next Distro, which are national mail order syringe service programs that are able to send supplies directly to people who use drugs in almost every county of the US. Who don't have access to brick and mortar structures in their brick and mortar programs in their state. So those are some facilitators that are really important to invest in.
Yeah, great. Thank you.
And I would second that as well. You know, I think every state that we've talked to has really emphasized the importance of the people that have been doing the work on the ground for a long time and tapping into those community-based organizations that really have a history and trusted role in delivering care to people who use drugs. So just wanted to reiterate that point. And we have a fair amount of data as well, you know, to help guide some of, you know, where that is, where the resources need to go. And I know that's been a big part of the saturation plans that states have done, I think, through the SOAR process.
Yeah. And, you know, I'm sure you're well aware of this, Katie. It's like the landscape is so varying, you know, like we send no cost naloxone to programs who don't receive a supply from their state, either because they are not eligible for the supply purchased by the state, because their very program itself is illegal in that state. The majority of naloxone that we send out, we send up almost 2 million doses a year to harm reduction programs. And the majority of that is in states where there is no robust supported harm reduction infrastructure, in some places not even legal. So
yeah, and that's something in the naloxone access study that we recently released. One of the things that we found just from surveying 119 harm reduction organizations, we looked at it regionally, and definitely there was, like, in the Northeast, states the organizations were much more likely to work with their state to access versus a buyer's club like Remedy Alliance. Whereas in the South, they were more likely to work with Remedy Alliance, in the Midwest as well, I believe. Yeah, so there's definitely differences based on, and I'm sure if we had broken that down by state, we would have seen much stronger even examples, right? If we'd been able to do that and look at the specific policies they're facing. Before we shift gears a little bit and start and talk briefly about OTC access specifically, I just want to remind audience members, if you do have questions, we welcome those. We'll just save them to the end. So pop them in the Q&A and we will do our best to get to that. But yeah, so I appreciate now, I think we've got a bit better understanding of the landscape of naloxone access. So let's talk a little about OTC status and kind of what this does and does not do of these intranasal formulations. And part of why I think it's important today to mention this is it's gotten a ton of press, right? Like this is something that we hear and sometimes I hear from folks, well, now it's available over the counter, so we're done. And yeah, I think it's important that we have a continuing conversation about are we done? Really? That seems like an amazing answer, but my guess is it's not the case. So let's maybe jump in and start with you, Rachel. If you can explain briefly what this shift to over-the-counter status does for folks who've been getting naloxone at the pharmacy. What are some barriers it might remove? What are other barriers it might erect?
Absolutely. And I think this conversation, I first want people to understand when we talk about going to the pharmacy, there's different ways you could get it from the pharmacy or now over the counter, but also we need to know what products are we talking about? When we think over the counter, we're mainly thinking Narcan, but that's not the only one. So I just want to first start with, we have our injectable products. None of them have been moved over the counter. So we're thinking there our Zimhi, our Evzio, which is no longer, I don't think, distributed anymore. So we have our injectable, they could be intramuscular, subcutaneous, or IV. None of those have been approved OTC. Then we have our intranasal. Some of the intranasal have gone over the counter. Narcan 4 milligrams is over the counter. I believe Revive 3 milligrams is over the counter. Now there's Cloxato, which is 8 milligrams. That's still RX prescription only, as well as Rextovy, another one that was FDA approved. That's also still prescription only. So we have our intranasal options, but of our intranasal naloxone options, or a version of that drug that's working the same way, not all are OTC. So when we're talking OTC, we're talking the ones we don't need a prescription for. You walk up, it could be in a kiosk near the pharmacy. It could be on the shelf where you go buy your regular Tylenol. You could walk up to the cash register at the front of your local community pharmacy and buy it. You don't have to walk back to the pharmacy. That's the main thing we're thinking about when we think moving it from RX only to OTC. Now, just because we have this shift doesn't mean those RX only options to obtain it were eliminated. So what are our pathways now? I think what this did is open up the pathways to obtain it. One, you could still have your prescriber write a prescription. They send it to the pharmacy. You get it filled, you pick it up. Number two, some states have given pharmacists the authority to prescribe it independently. Other states say pharmacists have to work with a provider in an agreement, but under that agreement, they can prescribe and dispense it. What does that do? That's one-stop shopping. You don't got to go to your doctor first, and then there you go to the pharmacy first, but the pharmacist is still essentially writing the prescription and dispensing it. Of course, we still have our community programs that Eliza and Katie have both been talking about. And now our fourth option here is you walk up, you need nothing. You don't have to talk to anyone. That is the OTC option. You don't need a prescription. You don't have to ask the pharmacist to write it. You don't have to go find a community program near you that has it available. In theory, you should be able to just go to your community pharmacy, which in theory, there is one within 5 miles of every person in the United States. That's what OTC does. It puts naloxone within 5 miles of you, assuming the pharmacy is stocking it. That's the key, assuming they're stocking the over-the-counter product. If they're not, then it's asking them, well, if they have it, that they could dispense. That's assuming they have the prescription only products still available. So I think it gives us another opportunity to buy it. When we ask what barriers does it decrease, I think the biggest one, stigma. We don't have to talk to anybody. We're not worried about our insurance being billed and we possibly being flagged by someone down the line because we got naloxone dispensed and it's on our profile and we don't want people asking questions why. So that stigma piece is a huge barrier. I think it breaks down. What remains? Cost. We don't all have $45 that we can go and get it. And that's assuming it is available. So a barrier that's, you know, it can cut both ways. If your pharmacy has it, that's great. If they don't, that's not going to be great for you. I think too, one other thing I wanted to hit on, which may be a little kind of down the line, but I get the impression that I don't know if every person that may be in a position to administer it to somebody, because while yes, we want everybody to have it, someone else, if someone's overdosed, someone else is going to have to administer it to them. I don't know if every person understands when to administer it or feels confident in doing that administration. So I think that, yes, I am an absolute proponent of the over-the-counter availability, but I do think we need to amp up education on how and when to use it. Yes, it is very easy, but I do think some of the pearls that get lost are make sure you call 911 immediately if you are administering it. And sometimes for our 4 milligram options, you give 1 dose, you wait 2 to 3 minutes. If something doesn't happen, you need to give them a dose again. People may be nervous giving a second dose. This is, yes, it's on the box of that OTC labeling now, but how many people are going to carry the box around with them versus just take the little device out and put it in their purse? Yes, the box tells us signs and symptoms to look for. The box tells us call 911, do this. I don't know how many people are going to carry the box around. So empowering people with this knowledge to know it's effective. The onset is 2 to 3 minutes. It's going to work in. If not, give it again. But call 911 because this will only last 30 to 90 minutes. Patient is still going to need additional care. I don't want that information to be missed in empowering individuals to be more comfortable giving it. So just kind of as a picture, we open up opportunities for how to access it. Don't need that prescription. We don't have to talk to anybody, decreasing stigma. If they have it, great. But also want to make sure we empower the individuals that want to buy it and have it or need it. They know what to do. They feel confident in what to do.
Thanks. That's a really great point on just like having that knowledge and comfort level with it, which I do think is part of where shifting to ELISA, right? One of the things that SSPs and other harm reduction programs often do, right, is we get actual training on identifying an overdose and how to reverse it, how to watch for the restoration of breathing. Maybe sometimes I've heard from some folks that there's an expectation that a person's given naloxone and they should just like sit up and be wide awake, as opposed to what you want is their breathing restored. But I'd love to shift to ELISA. Can you talk a little bit about what this status does or doesn't do to improve or hinder access through community-based organizations?
Sure. So as a sort of community of harm reductionists, we have been organizing and asking for the removal of the prescription status on naloxone since probably around 2004-05 is when we first started, including multiple meetings with the FDA over the years that were often spicy. If anyone would like to read those old transcripts, they're online. I have gotten into quite a few scuffles at those meetings. So I think that for us, the call was always a request to remove the prescription status of naloxone. So I am specifically focusing on that way of describing what we needed, which is not OTC. But the FDA doesn't have a middle designation. I mean, they have behind the counter at the pharmacy kind of stuff, but that doesn't work either. What we have historically been asking for is something that doesn't quite exist in terms of a regulatory status or category. The FDA sort of more generally and broadly thinks in terms of a drug is a prescription drug, a drug is an over-the-counter drug. And in order to meet the over-the-counter status, the drug has to go through a variety of different tests, human factor studies, all these kind of things, label comprehension, and the FDA was pretty supportive of that switch in the last few years, including making their own labels. But they really decided a while ago and made the decision that they wanted the decision or the application to turn a product over the counter to come from industry. So meaning that a maker of naloxone had to submit their product for the switch, right? So we have a new product coming on board as the first direct to market as over-the-counter nasal product in around January from Harm Reduction Therapeutics. But all the other products that currently exist are prescription that have to be switched, which Emergent did with their product. And then pretty soon, all of the 4 milligrams will have to be switched also, or they'll be non-compliant. So retail sale of naloxone at a pharmacy or drugstore or gas station was never the advocacy ask. It's a nice result for some people who are well resourced enough to be able to walk into a place like that and purchase the medication. But the real true ask was that they remove the regulatory barriers on high volume distribution of naloxone. So what we have now is actually a reinforced barrier for us. Our primary distribution is injectable naloxone, always has been for 25 years. We distribute millions of doses of injectable naloxone, which now is relegated to this sort of over-regulated status compared to nasal naloxone. So it's very frustrating for us. As part of the team of people who wrote the first standing order that exists for naloxone in Massachusetts, we really intended that to be a mechanism to expand access, and it did for a very long time. But now we are looking at still needing standing orders and blanket prescriptions for one form of naloxone, but not the other. And it's created sort of a tiered regulatory system that has actually added more confusion and reinforced some barriers. So
and it's noteworthy, I think, I don't want to interrupt, but that injectable naloxone is just as safe as intranasal naloxone. There's not like a tiered with regard to the safety of these two products, right?
No,
they're administered differently.
They're administered differently. I mean, the injectable naloxone is the standard. It's what we used forever. The nasal Narcan product was only FDA approved less than 10 years ago. So it is a new thing. And we have the FDA has stated that they will not remove the RX status for injectable based on their current kind of regulatory process, which means that you would have to label the product as an over-the-counter product. We actually don't care or need injectable naloxone to be on the shelf at Walgreens. It's not the need, but we need the prescription requirement to be removed for high volume distribution. So when we get later into some policy changes that we'd like to see.
That's definitely one of them. I do think something that's an interesting point that comes out, right, with regard to this high volume distribution is there are a handful of jurisdictions where restrictions on syringe service type programs operating and or specifically the distribution of naloxone has been historically so tight that this OTC status does actually improve their ability to access and distribute naloxone. So I don't want to ignore the importance of that for these particular groups. And even it does, a colleague and I were just chatting with a gentleman at University of Arizona the other day they worked really hard to get naloxone boxes in all the fraternity houses on campus. And this was something that felt like there were a lot of hurdles for them to go through before. and now there aren't hurdles, right? And so it's definitely, there is a place where this makes a difference, but again, we keep going back to this population level impact and helping as many people as possible, and that being the role of policy.
But I think that that's exactly what I'm saying, is that the intention was always to use the change in status to remove all those barriers.
Yeah.
You know, and so that is the greatest benefit of the change for me. You know, in Alabama, it's illegal for a harm reduction program to distribute naloxone because of its prescription status. Now it's the nasal product, at least, is no longer prescription status in Alabama. So you can distribute it all you want, except they don't have access to it. And so we are like, that's a great example, right? It's like we're sending injectable naloxone to underground harm reduction programs in Alabama who are actually afraid to distribute it, because even though now the nasal is OTC, they can't get access to it. So like the barriers are complex, and it's like a whack-a-mole thing where you sort of get rid of one and then a new one sort of kind of emerges. But yeah, there's many layers to the change and what it has done to the environment. So.
And I appreciate the sort of deep dive into the many implications of the various FDA regulatory statuses. And I think we've kind of beat the point to death that, you know, going into a pharmacy and paying $45 puts naloxone out of reach for a lot of people. But one thing I haven't really heard discussed is just the extent to which fentanyl has kind of changed the risk calculus and how we need to approach risk to overdose. And you know, prior, I'm not a clinician, but this is my understanding, your risk of overdose increased as drug usage increased and substance use disorders developed. And with fentanyl, you're now seeing increased lethality with occasional drug use or experimental drug use. And so how this is showing up, for instance, is in youth overdose rates, where there's been no increase in drug use whatsoever, but you're seeing doubles in overdoses. So I think, you know, this might not benefit sort of the people that we're really needing to focus in within the communities, but I think it does open up another avenue, you know, not only to reducing the stigma, so people see it in the pharmacy, so if people think, do I need that? But, you know, it can be in homes, it can be in schools. You can kind of widen the avenues that it's available to people.
That's a really good point, Katie, too, because the implementation of school-based naloxone access for students has been so fraught with barriers, like almost impossible to do. Like the best that places have been able to do is like get a kit or two with the school nurse, which we know doesn't have any impact. Like the actual students have to have it. And with the change in OTC status, like this is more of a possibility that you could actually implement youth-based distribution and school-based distribution that reaches students. I mean, still, there's many schools that still don't even allow the possession of over-the-counter medications in schools. So that is another little policy piece that needs to be adjusted to expand access. But like that is a huge deal.
Yeah. Yeah, no, definitely appreciate that. And you all have sort of taken us where we were going next anyway, right? So we've got a few minutes left, and I'd love to talk, maybe starting with you, Katie, if we can talk a little about the role of states in ensuring naloxone access going forward, and what are some avenues you've seen them take that work really well on the policy level? What could they consider? What are lessons we might learn from other pieces of health policy that you've seen?
Mm-hmm. Yeah. So I'll try not to cover things we've already talked about, but I'm sure I will. You know, as you know, we've been through a pandemic over the last couple of years, and there were a lot of lessons in and of itself, but also within the context of take-home methadone and lowering barriers to care. And I think that's really the key for me is low threshold services. meeting people where they are, meeting them where they receive their care. So in terms of the roles that states play, I had mentioned the naloxone saturation plans, which is not to say there aren't huge barriers, political and stigma and otherwise, within states. But in terms of, even if you're thinking about going back to the pandemic and how we thought about distributing tests, how we did vaccinations, the state played a really important role in purchasing those. They played a really important role in terms of data and improving data collection and knowing how to best utilize those resources and target them. And then supporting with distribution and partnering with community-based organizations. So we've seen harm reduction clearinghouses in some states. I know Oregon and California, that's a role that they play, where they play sort of a centralized mechanism where different entities can order, and they can provide support or funding or what have you. I think just generally engaging more and better with harm reduction entities and CBOs. So I think I covered a lot of ground, but
yeah, no, definitely. And I'm going to pop in one of these, a quick audience question, because it's relevant to what you just said. So are state Medicaid programs adding opioid antagonists to their list of covered over-the-counter medications without a prescription? If any of you want to answer that, is that something that you've seen in your work?
I know it's been discussed. My guess is it's something that states are actively considering, but I don't know the specific answer about how many formularies it's ended up on. But I don't have any specifics, unfortunately.
I do think it might have it. We were just working on some suggested edits to the new CARES Act. And I do think that there is something in there. I would have to remember, but that's a big thing that our legal team is always pushing for, is making sure that Medicaid plans are going to add the naloxone to those OTC meds. I think there's something happening around it. It's not my area of expertise, but.
And one more just quick thing I'd add around the state role is that naloxone is being purchased through a lot of different grants, a lot of different funding sources. State opioid response grants are a big one, but there's also block grant funding. There's opioid settlements at both the state and local level. The more that states can sort of think about these strategies and these funds comprehensively, and about sustainability as well. As a grant funded entity, I think everybody knows how tough it can be to think about sustainability moving forward. And when you have things that are flexible, like opioid settlement funds or state funds, I think finding ways to blend and braid and think about comprehensive strategies for harm reduction generally are really important at the state level as well.
Yeah.
Right. And then Rachel, do you have any specific policies that you have seen, heard about, that you think maybe serve as a model for other lawmakers going forward?
I don't know about serving as a model. I guess
That you would want to see.
To be honest, I would love to see people, pharmacists particularly, utilize some of the opportunities they already have. Many pharmacists aren't using collaborative pharmacy practice agreements, even though they just send it in to the chief medical officer of the state in many states. They just have to send it in and sign it. Do maybe a 2-hour training. We're not utilizing the tools that are already available. So I think sometimes too, it's what can we do within the framework we currently have? Some states are going to independent prescriptive authority. Some states, pharmacists can already do that. The thinking here is they only have to go to one place. They can go to the same place that has it in stock to get it. They don't got to go and get a prescription for it and then come back. So I guess my thought is trying to let's better utilize what we already have for those that may access it this way. Now, to Eliza's point, and Katie, what you've both brought up, this probably isn't going to be reaching the most that are at risk. I appreciate that. But from where I sit and the perspective that I bring, we can do better utilizing the tools and the resources and the leverage that we have to help patients. At the end of the day, that's what we want to do, improve patient care, connect them to treatment, use this as an intervention point to get them into treatment. I think that we've seen the federal government roll back much regulation on treatment aspect, because at the end of the day, we want to use naloxone to help the patient to then maybe intervene and connect them to care so they decrease their use. They get the treatment they need. They get the buprenorphine. They get the methadone, whatever it is that they need. So we've seen a lot of regulation at the federal level be rolled back on treatment. It used to be more difficult to get buprenorphine for opioid use disorder than oxycodone for pain. That's problematic and contributory to this problem as a whole. I think we need to see states fall in line and rolling back their regulation on treatment for these substance use disorders that many of these patients do have, that we have effective treatment available for.
And then Eliza, are there any key state and or federal policies that you think would make a huge difference at this point?
I think that on the federal level, I would love to see the FDA carve out a special exemption for naloxone where they use their authority to remove the prescription status for the whole molecule, and instead of relying on industry to drive the switch. And on the state level, I want to kind of really applaud or echo what Katie said about, I would have loved all along, as soon as there was federal funding coming through the states to support naloxone distribution, for them to have from the start adopted a similar rollout strategy to what we did with COVID vaccines, which was around a tiered rollout strategy that prioritized the most high risk people first, and then sort of rolled out access in stages. We have done the exact opposite in most states, where we have done massive rollouts to people who are least likely to use the product and who are least likely to be at risk of witnessing or experiencing an overdose. I would like to see a flip on that, and a more comprehensive investment at the state level with these federal dollars, whether it's opioid settlement or SOAR or PDO or whatever it is, into supporting infrastructure of harm reduction in addition to just naloxone. Like, we get a lot of federal dollars that support the drug itself for programs, but not staff, workforce development, the time, the labor, the energy, the expertise, and the skill that it actually takes to distribute the medication to the community. It would be like having a pharmacist not get paid to be a pharmacist. Like, get a lot
That's
of,
a whole other webinar.
yeah. You get a lot of naloxone to hand out and you don't get paid to do it. That's what we do to harm reduction programs. So
thank you. So we might have another question here. Yeah, we have a comment from an audience that's its own problem.
One of our board members is a pharmacist. I know all about it. We get a lunch break.
Yeah, and I think so. To follow up really quick on the Medicaid, I don't know that there's anything super clear at this point on Medicaid covering this as an OTC status, but as the other panelists mentioned, I've heard whispers from multiple places and seen some states start to introduce policy that would require their state programs to cover it. So it's definitely covering OTC naloxone via insurance is something that some states are considering. And it's part of the conversation for sure. So before we wrap up and give folks their days back and give you all your time back, does anyone have anything that you want to add? Any final thoughts for lawmakers, for the general public, regulatory institutions on this issue? No, all good. Awesome. Well, thank you to my wonderful panelists and to the audience, and we'll give you've got 4 minutes back to everyone's day. So yeah, thanks again, and I'll see you all soon.
Thank you, Stacey, for organizing.
Thank you so much for the invite and for organizing. This was wonderful. And it was great to meet both of you, Katie, Eliza, as well as the folks from our street. So, bye-bye.
Great work. Thanks all.
Great day.
Bye.